Okay, let's start. I think people will filter through. So welcome today to Newham Practice Council. I'll be chairing the meeting today. So just to remind everyone, it is being recorded, and if you can all kindly go on mute unless you are speaking. Obviously, please also use the chat function. It's always been sort of very good for us to kind of reflect back on what's written in the chat bar. So I'll keep an eye on that throughout the meeting. We have apologies from Wax today. He's involved in the vaccination summit, and Selena has also had to attend. And apart from that, I think everyone's here. So let's get started. So I'm going to hand over to Jason, who's going to give us an update on COVAX and obviously kind of a reflection on the call to action. So Jason.
Thanks very much, Rima, and hi everyone. Really good to see you. I guess firstly, kind of very briefly where we are in the epidemic, because I think that's really relevant, clearly, and I guess you will all be seeing in your work an uptick in cases. So we kind of bottomed out in early May, where we're getting a very, very, very low number of positive cases, roughly 5 a day at that bottom. And then since then, and since the Delta variant has been seeded locally and across the city and across the country, that rate has been climbing, and it's climbing pretty consistently. And we probably have had, rather than 30 cases in the last week, which was the best we had at early May, we're now up to kind of 250 in the last week, and that's climbing pretty steadily. That's mostly being seen in younger people, absolutely, mostly probably in unvaccinated younger people, but I think we all know that will spread, and that the higher the rates go, the more the wider impact of that will start to be felt across the wider community. And that brings us to the kind of the challenge that we have with the vaccine push. Yeah, I think we've done really, really amazingly in Newham, and thanks to everything that everyone on this call has done to contribute to that. We're up to about 180,000 first doses in the borough, and we're over 100,000 second doses in the borough. And when we look, not the best in comparison to many other places around the country, we all know that a huge factor in that is the age structure of our local population. We have an extraordinarily young adult population, totally different kind of shape of population pyramid to most other local authorities in the country. Even some of our neighbours in outer East London look entirely different in terms of the shape of their population. Most of our adults who are eligible for vaccination, 18 pluses, are under 40. So most people are only eligible, for Pfizer, have come on to eligibility reasonably recently. We've been faced with the challenges of availability of Pfizer vaccine. So, given that context, that speaks a lot to where we are and where the position is. And I think, clearly at the vaccine summit that starts in 20 minutes, those points are going to be made really, really clearly. However, with the rate going up, we've, I think, got 3 challenges. One is to really reach this younger population, to maximise supply, and I believe if we can put on convenient, local, accessible clinics for young people, they will come. We did, which some of you were involved in, an amazing clinic at East Ham Leisure Centre, for example, 2 weekends ago, where young adults queued for up to 4 hours in the hot sun in complete calm. It was very chilled out for anyone who was there, to get their vaccine. And I believe really strongly that if we create the right conditions, people will come. So we need to continue to do that, really, really reach out, work to get the supply, work to get the support, but get young people there. We need to get people their second doses. As all of us know, with the Delta variant, it's absolutely vital that people get their second doses. But I think actually, if you look at the data, whilst we know there's a bit of AZ second dose hesitancy, actually the data is pretty reasonable. And in the older cohorts, who are the ones who've become eligible for a second dose, actually the uptake looks pretty reasonable for those who've had a first dose. And we need to keep that going as we get to the kind of 40 to 40, 50-year-olds who are now eligible for a second dose. And the third is that we really need to reach out into those older adults who've not had any vaccine at all, those who have been hesitant, because we know, all of us, that those are the ones most likely to become most unwell. And again, every single vaccine to someone unvaccinated, who's 50, 60 plus, is actually worth a lot of vaccines to a 20-year-old. That effort really is worth it, because we know that the clinical impact is that much greater. So that's where we are. I know colleagues on the call will speak more about the detail of what the next stage of plans is. John, Will, Karen. But I guess my ask to you as DPH is please to do. I know you're doing a lot, and I know it's full on with a whole range of clinical challenges that you face right now. But whatever we can do over the next couple of months to really hit those 3 goals, and any support you can give, whether it's through that call recall and reach out to your patients, to have staff involved in the vaccination program, to be that constant reminder that making every contact count for every possible opportunity where it will make a difference. So that's all I wanted to say. Real huge thanks for all of your efforts to date, but a real ask that anything you and your colleagues and your practice can do to help us, get that bit further, hugely appreciated.
Okay. Thank you so much, Jason. And I just want to sort of echo as well that there's just been an enormous amount of effort through across the organisations as well. In primary care and HC, we've just done so much work towards this, and we just want to keep it going, and the momentum. Everyone's exhausted, but I think we just have to keep going, especially now with the new variant sort of increasing in numbers. It's even more paramount that we have to make the effort to kind of, still roll out this vaccination programme. I'm going to open it up to any questions or comments. To anyone. I know we're going to be covering it later on. William, we're going to be covering it from primary care perspective, but if there's anything that anyone wants to say at the moment, or any questions for Jason? No?
I think Karen's got her hand up.
Oh, has she? Sorry, Karen, I didn't see. Sorry. Yeah.
Not at all, Rima. I just wondered, Jason, might it be worth sharing with colleagues a little bit about the work we're doing to reach out to some of those very vulnerable groups? So you identified that sort of issue of, sort of the balance between the high volume and yet those that are still very vulnerable. And I know I can share, but Jason can perhaps add, with public health assistance, we are putting in some intensive work around reaching out to those, individuals, and it is individuals, piece by piece, to try and make sure that our coverage is as comprehensive as possible. But there is something about GP practices being very closely part of that, because the relationship you have with patients and their trust in you is critical to us being able to reach out to some of those individuals that are quite anxious. I don't know, Jason, you might want to reflect on that.
I mean, just to say, and again, I think Karen will share the details, but we meet weekly, multiple times, and really will do anything to reach out to our different patient groups, whatever the needs are. And clearly the needs of a vulnerable 75-year-old who still won't come out to a vaccine centre are very different to the 22-year-olds who we need to create flexible drop-ins for. But if you've got patients and you think there's something in the way the vaccine program is being delivered that's not meeting their needs, we will find a solution to that. We will absolutely find a solution. But we need your insight and your intelligence and your relationships with your patients to be able to do that, and to work with you with your patient knowledge, and we'll together we'll work on the solutions. And I did want to say one more thing, actually, which I think is I'm feel really strongly about, and I know this is kind of not national government policy, but I'm going to say it anyway, which is that for older people who have said no to the AstraZeneca vaccine, it's absolutely vital that they get vaccinated. And very clearly, all of our Pfizer, a lot of the Pfizer clinics clearly say for anyone 18 plus. And if you've got patients that have older patients who are likely to become unwell if they contract COVID, who just implacably will not have AZ, it's really important that we get them vaccinated one way or other.
Yeah, and we have better stocks as well now, so that's just equally as important to get that message out to say, look, we have got lots of Pfizer clinics, got lots of slots available. So, you know, the issue previously was not enough vaccine, and now we've got that supply, so we need to use it up, basically. Yeah. Okay, thank you. Any other comments? Nadeem, do you want to ask your question that you put in the chat?
Yeah, patients who've had the AZ and want to fire the second dose. Any idea on the timescale about mixed vaccines and when we'll get those guidelines?
I didn't hear the question, sorry.
Sorry, can you hear me now, Rima? Or?
Yes, background noise. Do you want to just say it again?
Patients who've had the AZ and want to fire their second dose. Any ideas about when we'll get guidelines around mixing vaccines in that cohort groups?
I don't know. That's that's clearly been talked about for quite some time, and but no, I don't know when the guidelines are going to come out around that. I think the one thing, and I know that you can only get so far with. I think the one thing to keep communicating to patients is all of that kind of that evidence around AZ risk is heavily concentrated in first dose rather than second dose. And I know that won't be reassuring to all, but hopefully it will be reassuring to some. And that's all we can do at this point.
Jason, there are 2 more questions. Just one was around how early can patients book for their second dose?
Oh, Karen, were you going to say it's 8? Yeah. I mean, I think I've just come off the call where it's been really reiterated that it's the 8 week is the early limit.
Yeah.
So we want people between 8 and 12 weeks. Yeah.
And the other question was, can the younger cohort who've had the first dose go for the drop-in for the second dose earlier than 12-week wait? And my understanding is yes, they can.
8 weeks, yeah, absolutely 8 weeks. Good fingers, Karen.
Imrana's got her hand up. Imrana.
Yeah, hi. Mine's just a comment really, and hopefully a little bit of encouragement. So, I mean, I'm speaking to the converted. We all work in the deep end, and we know how the multiple layers of complexity is just confounding problem after problem. I've got colleagues who work in other areas who've said they sent out a text message and 2,000 booked. And in Newham, that's just completely. So basically, what I'm trying to say is that although our numbers are amazing, but some places look fantastic compared to that. The amount of effort that each and every one of us are putting in to get that far is, I'm not sure. I don't know if there's a way to articulate it in a way that we can capture how complex it is. As a very small example, then the patients on our list who keep changing their mobile numbers, either because they lose it, they get stolen because of the situations they're in, they don't have enough money to keep going on a continuous contract. It's such a simple example, but if we can't reach those patients, and then that simple text message, book an appointment, clearly doesn't work for that. So I mean, I didn't want to say that to make it to sound depressing, but also just to kind of acknowledge the amount of work that each vaccine takes. And then obviously later I'm going to talk about mental health patients, so I'll leave that for then.
That's totally right, Imrana, and I talk about it a lot. We did a vaccine stories night with our COVID-19 health champions a few weeks ago. And I've said a lot since then. One of the remarkable things about that was that no one told the story as I got a text message, I went on and booked. Yeah, that's no one's story. And, they had one of their son or their daughter help them, or their GP had, really supported them to do it, or someone from their faith community, or there's someone somewhere was part of that person's journey and experience to getting the vaccine. And I do think it's a massive difference. And it's about language, it's about technology, it's about confidence, it's about ease. It's so many different factors that play into so many people's experience emotionally. So yeah, totally recognise that.
Okay, go
on. Jason, I've got a question from Laura. It's about the testing actually. So in terms of communication around the PCR and the lateral flow tests. Laura, I don't know if you wanted to come in.
Yeah, I've got really bad reception, so sorry if you can't hear me. But yeah, it's just, I know that a lot of other people are in the same boat as us, that I feel like a parrot to keep on talking to patients about when to test PCR, when to do lateral flow tests. There's certainly been a lot of misunderstanding about it, I think, nationally. But are there any sort of local initiatives about how we can actually advertise this more. I mean, I was thinking, you know, I Plato text out to everyone for it because it causes such difficulty when we're trying to care for our patients and want to bring them in safely. And actually, you know, they might have had a cough for 3 or 4 days. They could have had the COVID test by that point, and then we know how to manage them safer. It's causing quite a few problems. So I just wondered if there was any initiatives going on with that.
So we're constantly trying to get the messages out, particularly through our champions, through all the infographics we develop. But if there are more things we can do, and we can, you know, one thing is we can share all those infographics with yourselves so you can cascade them. But if there's any things you think we could do to support and help you around that, just please let us know. But yeah, we constantly have all of the trying to make as straightforward, as complex and messy as it is, make it as straightforward and understandable for our residents, the messaging around that.
Is there someone I should email about that to sort of to start the conversation?
Why don't you email me first, Laura, and then I'll bring it into I'll bring others into that conversation.
Okay, thank you very much.
I think Laura's point is really valid, actually, Jason, because even we're sort of seeing some hesitancy in getting tested. They just presume that they don't have it and they don't actually want to get tested. So I think we may need to do some kind of more communication around that. I'm going to bring in lastly Dr. Patel, and then we can move on to the next agenda. Dr. Patel.
Hello. Is a quick question. Most of the time, many times, our patient has got a landline only. What do you do about that? Because you see, then if they are not contacted, many they can't afford it, and sometimes they have a 2 mobile. So do you give messages to 2 mobile? And how do you deal with only if somebody has no mobile?
Karen, did you want to answer that?
Yeah, thanks. We have a calling team, Dr. CM, who will ring people directly and book them on the telephone. So in terms of that landline contact, if there are patients that you know that's the issue, and sometimes it's apparent because obviously the number is not a mobile number, but sometimes we just have no record of a contact number. So where practices know actually we've got a landline for this person for whatever reason, it's not been properly captured in the system, then we can ring them directly. And double mobile numbers, we have one, so the system does the preferred mobile number. So basically there's one that's indicated as your lead mobile number on the record. It would need the practice to change the number. So if you had 2, it would need the practice to say, please put mobile number 2 as their lead number, if that makes sense. But you can certainly change it to switch from one to another.
Yeah, I have to go through whole patient's list to do that, so it is not practical. But I thought I just put this query.
Thanks
all. I'm going to go to the summit and try and get us some more vaccine. But thanks again, and do always be directly in touch with me if there's anything from public health that we can do to support you around this or other things. All right, nice to see you all.
Thank you, Jason. Thanks very much. Okay, let's move on to the next agenda item. So Celine is obviously unfortunately able to attend today. So John's going to talk through a bit about the ICS and give an update. John.
William, I welcome your input into this. Should you wish to? So sure. So we're aware that there's a new ICS coming from the 1st of April. We are expecting legislation to be passed fairly soon that would see the CCG become part of a new ICS, and absolutely central to that is a strong and vibrant primary care within it. So what does this new ICS talk about? Well, it's effectively a new statutory NHS organisation. It will have a footprint of being North East London, matching the shadow ICS that we've had, but as I said, in statute, and it will be form a new board which will govern all things with the NHS. It will also form a partnership board with local government at that North East London level too, and we'll have GP representation at that board. The other thing it relies upon, importantly, is the creation of place-based partnership or borough-based partnerships, which are absolutely focused on those communities, deeply rooted within it, and beneath those partnerships, very closely aligned to the neighbourhoods that exist within it. So we've got a developing borough partnership, and I'm going to touch on a little bit later what we're doing to think about how we take our role across primary care, community services, mental health, social care, acute care, and so on, our engagement with the voluntary community and faith sector really seriously, and how we discharge the roles and functions of the ICS within it. So making sure we retain that Newham focus, whether it's on things like vaccine, whether it's on the delivery of good care to our patients, whether urgent or planned, is clearly going to be something that we need to build for April, when we're expecting the legislation will bring in all of these new changes. William, did you have anything to add on the primary care bit? You want to...
No, again, really happy with that. John, again, is what I would say is obviously we're looking around, certainly around engagement with the PCNs as well as that. So again, working certainly with WACS and yourselves, just to kind of what does that look like. So I certainly we'd want to bring this back of what that kind of structure would look like and how people get into the conversation, so that we're able to be representative of the membership.
Thank you. And we've got this thing called the Newham Executive now, which is sort of the starting position of what our partnership board looks like. We'll be looking at how that's constituted, how that's represented over the coming months, to make sure that we've got a really strong discourse between different parts of the care sector to make sure that that's truly represented. I'm going to talk about some of our plans in a second. I'm happy to pause there for any questions on that particular impending change.
Hi, John. It was just a question. Is there any flexibility on how the board is actually made up, or has this been set kind of on a more national level?
The ICS board is quite clearly set out in the new guidance arrangements around how that representation is achieved. So there is a GP representation on that. There are also representations of acute trusts and others. That's quite clearly set out. At a Newham level, we have more flexibility. So it's that may change. We know how much NHS England likes to prescribe stuff. We know we have to stipulate exactly who meets and on what day. But at the moment, we have flexibility in doing that. Again, thinking about how do we get the most productive and proactive approach between all of those different providers, hopefully in a way we've not done before.
Yeah, and I mean, I think we have to go in with it thinking positively and openly, but you know what my thoughts behind it are, that there's one GP representative on the, you know, it hits you straight away, doesn't it? And just, are we sure that, but I'm sure there's going to be community providers on the board as well, which will also represent primary care. But it'd be interesting to see how it pans out and how that GP gets selected and how they can represent all of NEL, and how, you know, and actually, is that going to be a strong enough primary care but general practice voice on that board? So that's just my, and I'm sure other people are having the same thinking at the moment as well.
William, do you want to come in?
Just on that point, so I think a really valid point. I think very much about what is the support that man or lady is on that board. How are they going to get all of that information to be able to feed up and feed down? Because it has to be a two-way process. So again, as if people have got ideas, happy to receive those, so we can then start helping that shaping or thinking of that.
Well, we do about 90% of the contacts, so I'm just thinking maybe that's why I was wondering how prescriptive is it, and whether there's any flexibility on actually having more representatives from general practice there. But let's see. Let's hopefully something might work.
So I would probably say that actually having one GP at the NEL level, I mean, obviously it doesn't seem to be enough, but it's actually the local borough-based partnerships that need to be stronger. That's where you need all the clinical input, because at the end of the day, it's the borough-based partnership will be shaping what's required for the borough. Nell will be there dictating, in a way, not, well, I don't like to say dictated, but might be sort of top heavy to say this is what needs to be achieved, but it's the boroughs that will be having that sort of, ability to communicate with everyone, all the partners in the borough, to shape what's required. So I think that's where the clinical input is really, really important.
I agree, Rima. Yeah, I agree. But how it, yeah, I think also, yeah, it's just that I think a board should be representative of the care that you want to provide, whichever level it's at. So I completely agree at the borough. I'm going to stop talking. I haven't got my hand up, so I'm going to stop.
John,
I think it's fair to say there's a similar sort of voice from social care and local authorities as well, to say, actually, although they form a partnership board with this new NHS construct, how do they make sure that they have that real representation? Again, that will be very much achieved at a borough level, but it's also making sure it's influenced. Rima's absolutely right. I think our knowledge of different structures over the last 20 odd years is that water runs pretty fast downhill. So I think our implementation, our agility at a Newham level is going to be really important. We've seen that very clearly with vaccination and COVID response. It's our local response to it that's important with the services we deliver, and that's what we need to get good at.
Absolutely. Thank you, John. Thanks, Rima.
Shall I move on? On the next slide, please. William, do you want to do this one?
Again, so again, is what we're looking to do. Again, is following on the original conversation. We're looking to from point of view of the team, my team, again, basically looking at getting a place-based primary care lead. So again, as you'll be aware, there's been a vacancy in the team. So again, will we very much be place-based to support the borough and the local development of that. Again, just working with WACS and the LMC just on the local decision-making processes. So obviously, kind of how we make sure that the decisions are very much done locally rather than, as you were saying, top-down, but making sure that we do link into the NEL system. Again, what we were going to be doing is working with our PCNs and CDs just around looking at what as an organisation from a PCN footprint of kind of helping them kind of work through their functions and the understanding of what the role is, but also trying to look at how we kind of develop some of the services across both at the borough level, but also as a TNW level, as been able to look at that and look at what the opportunities are. Again, working through, we've obviously, thank you for those that have applied for clinical roles and congratulations to those that have got those. Again, really looking forward to working with you and actually just looking around how we develop those roles. Also, again, is supporting the clinical leadership team, but also making sure that, again, they play quite a strong role within any kind of partnership or change to pathways or any kind of shift of activity work. Again, we've just talking through WACS around kind of, would it be helpful around developing regular webinars just to kind of talk us through around how we do that engagement for all around how we get that clinical voice up the line, both at a borough level, but also kind of at a NEL level and actually having that two-way kind of view. So again, as we'll be looking to socialise that within Newham on that. Happy to take any questions on that.
Claire, do you want to come in and then I'll bring Martin in?
Yeah, sure. No, I'm just a bit concerned about the capacity of the GPs because they're all busy running their own practices as well as doing the PCN work, and particularly the ask of the CDs. And I'm just wondering how much of the CDs are going to have to be playing into this borough partnership, and how is that going to be supported? And how realistic, because there are about 10 of them, or there's more than 10, so the impact's quite broad on primary care.
So really good question, and that's the whole point of around being able to have these conversations. So actually, what does it look like? What's the role and responsibilities of that? And then actually, do we need additional capacity or funding that actually gets additional staff or support to do so? But actually, it's really asking, where is the kind of appetite there, but also the time quantity, and then like you're saying, is how does that crystallize into those, because it's not just obviously the CDs, there's obviously the clinical leads and other roles that we can also play into to make that clinical voice heard and distinct.
I guess it's about trying to use people's time most effectively, because there isn't a big pool. Even if there's money to compensate the practices, they can't get the quality of leadership of GPs back into the practices to backfill.
Sure.
So it's just
Claire, any ideas on a postcard? Happy to receive it, because actually, you know, this is again new to us all. There is no, although there is a diktat from the centre, I think this is up for us to co-create, and I think that is the opportunity, but also it's the threat as well.
Thanks, Claire. Martin.
Yeah, my comments were really going to mirror Claire's really around capacity. CDs and you know already have a huge amount of pressure in terms of their workload, and some CDs are also sort of taking on clinical lead roles as well. It's just so it was really going to just echo Claire's point and on how this will look. In addition to that, I do think CDs could potentially engage in this if they do have that extra support. So there may be a sort of capacity issue. So it would be great if, you know, we could have a discussion. You know, I'm a CD for North Newham with the wider CDs across Newham about what we need in order to engage, because it's important that we do engage in the process. And I'm sure my colleagues, I can't speak for them, but I'm sure they do want to also engage. But it's about being able to have the time and doing so in an appropriate way that allows us to work effectively. Thanks.
Really up for that conversation.
Thanks, Martin. Really, yeah, you and Claire have really valid points. So I think it's something we certainly need to sort of address in our kind of workshops going forward. So thanks for those comments.
Let's move on, should we, Rima? Yeah. Next slide, please. So in terms of clinical leadership, we've just been touching on this. We have interviews are now taking place for 13 out of the 18 roles. We've got 2 roles which are still to be interviewed for, and we are still seeking leads for children, young people, learning disability and autism, and maternity in early years. So if you know of someone or yourself would be interested in those, we're really keen still to fill those as soon as possible. There's a real open invite to think about that. Think about the people, not just necessarily the GPs in the practice, but other staff within primary care who might be interested in taking those forward. We'd really like to hear from you. We have for those people who have been appointed in the clinical lead roles, we have an induction evening on the 7th, just to work through some of the support and the requirements that you have, and to make sure that that's in place from the outset. So really keen to have that as an open dialogue about how we can make sure that the clinical lead roles can be the best we want them to be in Newham. So look forward to seeing those newly appointed clinical leads there, and as William said, congratulations on those that have been appointed. Okay, I'll move on if that's okay. So the other thing we just wanted to touch on was what do we want to achieve in this borough-based partnership, as we start to think about its importance in the new architecture and its importance as a collaborative of different providers coming together to achieve those things that they can only achieve together. So really thinking about what are the challenges and particular issues in Newham that we want to address, and also what do we need to build in terms of our own capabilities, relationships and culture, including the workforce, to be successful in doing that. So we could just move on one second, thank you. So just thinking about the partnership, and we'll share these slides, but is what are the capabilities, what are the principles we want to operate under as a group? And we've been starting to develop these. They're not finalised yet, but start to think about well, our starting point has to be the needs of the population of Newham. We want accountability as close as possible to communities in our neighbourhood and to our care teams, and to support that. We increasingly, where it's appropriate, want to build integrated teams and pathways. So just the work we've done during COVID around the development of integrated discharge hub has been phenomenally successful in getting people out with the right packages of care, and that's the sort of thing we want to replicate. Our response recently in the vaccination programme is a very much blended approach of different providers that Jason talked about, particularly trying to find the hard to reach. I know Imran is going to touch on some of that later around mental health. Really recognising the voices and listening to service user and staff experience to make sure that we start to measure those as outcomes much more frequently, and staff's ability to work in a system where they are increasingly integrated, they are supported, they do have the right data, I think is absolutely crucial in assessing how well we're doing this. We've not done that well over many years in care of thinking, particularly around staff experience, better on service user, but I think listening to the whispers as well as routine listening mechanisms of service user is something we really want to build. The next one is around clinical and professional stewardship, so making sure whether you're a social worker or you're a GP or a hospital consultant, you're increasingly part of the design and implementation of our services and our care offers, and making sure that is richly embedded. We know international evidence tells us that the most effective care organisations, care partnerships are built by having that in place. The next principle we're looking at is how do we get the most value out of the money we've got, and I think, as I touched on earlier, in measuring those outcomes and thinking about the stretch of the Newham pound, whether that's through the council tax in the council or NHS resources, how do we increasingly get the ability to measure the relative value of different things we do, so we can get more precise and better value out of it. And then I think making sure that across all these partners, and you see those logos in the top right, that across and with those partners we are committed to implement some of the plans we create. So next slide, please. And in doing that, we recognise we're a new and emerging partnership, so there are things we have to build. So we're looking at how do we measure success, what's the people and culture going to be, thinking about what workforce do we need to deploy, what workforce do we need to deploy for the hard to reach, what leadership we have and what vision we have, and I'll touch on the vision in a second. So we started to think through all of these things that will help us become really successful and support a NEL ICS in its challenges. Next slide, please. And so I'd call out just a couple of these ones. So I think there's something particularly around how does the Newham pound work, and how do we work that across traditional buckets of health and social care. So I think we need to think more creatively around some of that, as well as, you know, we've got within there how we increasingly communicating, engaging and listening with people to make sure those offers are truly responsive to their needs, and we are culturally competent in how we're delivering different services to different parts of our community. Next slide, please. So one of the things we've been thinking about is, well, what does this partnership want to achieve? So thinking probably for the first time across health and social care, mental and physical health, commissioners and providers, what is the plan that we want to put in place? And this has been built very much based on the need. So over the past few months, we've run through a process. If you go to the next slide, which is, as I said, we start with what do we want to achieve as a vision, and then thinking about what are those needs. So starting with the needs. So we've been looking around what are the most important things that we think as a partnership of care providers in partnership with the voluntary and community sector we can best respond to and we should prioritise. So we ran a series of sessions with the public, with the voluntary sector, with clinicians, with social care staff, to start to identify some of those needs and then start to set those priorities. We're at the stage now where with those priorities, we're now thinking about how we want to respond to those, and what are the outcomes we want to achieve, and that's where the detailed service design comes in. So when we look at when we look at, say, something around learning disability in adults, what are the outcomes that those individuals prize most? What do we want to achieve for them? How do we deliver a model of care and an offer for them that most consistently delivers on those outcomes? And that's the phase we're in now, is much more detailed design with service users and staff we're about to embark on, which will help us then think about over 5 years, how would we implement. Next slide, please. So this is the vision that we established. I think the crucial part of this for me is the reference to the diverse communities, and that focus not just on health but well-being and independence, and the ability to access those services, but delivered by a workforce that's proud to work for Newham. We really want to create this as an opportunity to attract the very best staff and ensure we've got the right training and retention for them. And that's something we're thinking carefully about. Next slide, please. So from those needs, started to look at 3 different parts of the population, 0 to 25, working age adults and older people. And we felt that the needs we could best contribute to as a partnership was these ones set out here. Now, some of you will say, well, these are quite high level and they are wicked problems. When you look at things like obesity and nutrition, we know we've tried many things with this, but we're now thinking carefully about how do we leverage the resources we've got to do some of this more effectively than we've done before. We recognise we've got to offer people really robust and understandable urgent care offers. How are we going to do that responds to the growing population and their preferences? So again, as I said, thinking about those outcomes, but also you see that grey box on the left hand side, which is the 50 steps to a healthier Newham, which is our health and wellbeing strategy. How we also think about the wider determinants of health, whether it's employment, air quality and others, and our role in supporting that. Next slide, please. So what came through really strongly from the service users and representatives of the voluntary sector was some of the principles and challenges we had to consider. So we want to make sure we are doing this through that clinical and professional leadership. We want to make sure it's co-designed. We want to have that wide membership and involvement, but also we don't want to create a great big infrastructure for doing this. We want to use wherever possible opportunities we have. The really powerful things which set us a baseline expectation of how we do this is being very focused on inequalities, being very focused on who attends and who doesn't attend some of the services we have available to us, recognizing that we have variations in what we've called health literacy here, people's ability to navigate the system and understand it. We talked about that earlier with vaccinations. So there will be a kite mark associated with, have we involved people properly? Have we very much looked through this as an inequalities lens? And have we thought about that cultural competence in establishing responses to some of those needs I touched on before? Next slide, please. So we're very much at the start of doing the design work now of how we're going to do this. This will involve many of you in this process, particularly those of you who've been appointed clinical leads for some of these areas, working across and with partners and with service users about thinking what we want to build over the next 5 years as part of our role as a borough-based partnership.
Thank you so much, John. You can see there's enormous amount of work involved, everyone working together. I'm going to open up to any questions.
Yeah, hi. I've got 100 questions, but I'll try and limit it to one. It's really interesting to see the presentation, in terms of what and why. It's good to understand what some of the guiding principles are. It's very strategic, and part of me's thinking it's another strategy, what is going to be different. I'm really interested in kind of understanding more about the how, and I'll give one example. For me, there's a real kind of gap around resources. You've talked about the Newham pound. I'd like to see a kind of a priority investment coming into Newham and resources in Newham supporting the delivery of services, because it feels to me that the makeup of the partnership is almost set up to maintain the status quo. There's something about risk and reward. We need to shift the money around to support a shift of work into general practice, because that's what's happening. We need to support the resourcing at the point of delivery. I don't see anything which kind of says, or even kind of implies a commitment from some of the other partners around shared risk, shared reward, and moving money around to support system delivery rather than kind of individual organisational objectives. So it's I'd like to see more about the how rather than kind of the what and the why. And I know it's early days, but the resources and investment into Newham and into general practice for me are really big priorities.
And I think the most effective partnerships have challenging conversations and are able to do that. And I think if you talk to any different part of this partnership, they would all register their challenges around meeting demand. So we've got some really difficult and tough decisions to make. I think you're absolutely right. There should be something about when I touched on the value. Who's going to deliver the best value? Where are we going to get the most from? And what does that mean for the shift of resources? And a measure of success is the increased liquidity of financial and human resources around the system, whether that's moving people to more preventative work, whether it's moving capacity of staff to harder to reach groups. That's not easy when you're trying to service the people who are turning up today. I think from the financial side, we have to think carefully about some of those in terms of value of services. And I think we've seen from some of our community health design recently in Newham, where ELF has said, actually, we think the voluntary sector can do a much better value job for us in delivering this. And I think increasingly we're going to have those discussions. Those sort of things sort of hark back to the old health authority days of many moons ago, where you would be sat around saying, should we have this newfangled thing called a cardiologist, or should we have a bit more dentistry? And I think that's really where we've got to locate ourselves in once we understand what the financial regime is going to look like for next year and beyond. And I think making sure that we get a really strong argument for greater resources into Newham because of the need. We have a younger population, which means on the whole we tend not to get resources deployed in the same way other parts of the country do, but at least within the ICS and London, how do we make those arguments stronger because of the need and diversity of our community?
Can I just have a quick follow-up, because all of that links with the earlier conversation. In order for GPs for general practice to be effectively and strongly represented on the partnership or in any arrangement, as has been said in the chat bar, it needs a strong, cohesive, united general practice voice for Newham. There needs to be strong, effective, robust leadership. That is not going to be a single CD, no disrespect to anyone. It's not going to be NHC, it's not going to be the LMC. It's going to be all of us working collectively and making sure that collectively we're all representing general practice in Newham.
And I think what we're seeing as part of these changes is these borough-based partnerships. We've seen provider collaboratives being talked about, so acute trusts working together on the most specialised care, mental health trusts working together on tier 4 CAMS beds. It's really important we have a really strong provider collaborative for general practice, and that's a voice of general practice for and on behalf of the populations you represent. That list-based stuff that we know and love and is essential for how we do that, but also how you collectively deliver, and that's in support of partners, but also making sure that they support you as well. I think that's vital, and I think that's something we've got to work through, particularly looking at how we support and develop NHC, how we support and develop our PCNs as part of that.
Okay, that's great. I'm just conscious of the time, so
Sorry.
Thanks so much, Greg, for your input. I just wanted to quickly add, I think trust and relationships are really important in a partnership, and that's not only obviously all the strategic stuff, but when you mentioned sort of the how, I do think those things develop over time, and I know we're working hard kind of maintaining that trust and developing those relationships between the partners. Okay, so I'm gonna, if there's nothing else, if you don't mind, I'm gonna move on. I just want to thank John for that presentation as well, and hopefully be able to circulate those slides. Perfect, thank you. So I'm going to hand over to William now, who's going to give an update from primary care and COVAX within primary care as well.
Rima, if you could just tell me which slide I'm on. Is it areas of update?
Update areas, yeah.
Yeah, sorry, I can't see the slides on that. So just to update you today, just around the system pressures, the access improvement program, obviously the SNS and the COVID support funding. The new DES has come out, obviously long COVID and the weight management DESs, and then just a quick update on where we're at with the COVID vaccination program that I'm sure you will all know anyway. So just around system pressures, obviously you'll all be aware, and I know there have been various conversations that you guys are struggling out there from point of view of capacity. You've never seen the number of patients kind of knocking on your door or ringing or online. So it was really just to kind of, I guess, share that kind of information across the patch that I think everywhere is experiencing this extra demand, and really kind of obviously the low acuity of that. And again, thank you all for all the hard work you're doing in trying to manage that. And again, is the Federation, again, a big thank you for them for around supporting the kind of additional 111 appointments for LAS and the 999 calls. But just on another point, just again, people, if we can look at your contract and certainly your diary appointment that you should have as part of the contractual measures, there should be appointments in there for 111. So currently they have one appointment per 3,000 patients. We're acutely aware there are some practices that aren't offering any, or certainly on the system they're not offering any. So I would kindly request that people just have a quick look at that system and make sure that is happening, and try and spread them over the day, and obviously so they're able to do that. Again, just as a bit of more of an aside, so some of those patients on the low acuity are being sent to pharmacies. However, just the readout, and again, it's not ideal, but actually a lot of patients won't go to pharmacy for that, which isn't ideal, but it's just managing that as a kind of system pressure, I guess. And I see, Rima, we're going to talk about it later on, so I won't dwell on this. The Access Improvement Programme, this is an offer to all practices. So basically, this is the Time to Care team. I know some practices have engaged in this. Again, I know you're pressurised at the moment, but ultimately this is an offer for certainly across TNW. There's 7 practices that the system can support. We're going to be sending an email out so that practices can self-nominate for this scheme rather than kind of knock on the door. We will be ringing practices just around kind of where we feel they may benefit, some support on system processes and where you're struggling. So actually there's some additional support there, but also there'll be support around project management and kind of a data analysis and that kind of stuff to support that kind of package of somebody coming in to assist and work through the systems and processes. I'll rattle through this and then questions at the end. So SNSs, so some good news here. So you've got the income protection for the month of July. Obviously, the quarter is under review. So as the COVID and the pressure continues, that obviously we will be in reviewing that situation. But ultimately, the payments for funding have been supported. Again, there's lots of letters that have come out to you, so apologies for bombarding you this week. But I know there has been quite a few. So the COVID support funding around that has also been sent out to everybody. Again, if people can make sure they record what they're spending that money on, just for our auditors, because obviously we will be audited of what the money's been spent on, around making sure that the recall and call system, again, just reminding people around the support to the federations on their R's funding. And actually just trying to make sure that we utilise all of that R's investment in Newham so it's not lost. That would be really, really helpful. And again, as if just again practices again is with the MECC principles to encourage the uptake of that as well. The NHS England long COVID management service, they've been sent out again more information for you again this week. So sorry, it's been a lot. What I would say to you is certainly for the weight management, it's actually relatively easy to do. What I would say is, can we, implore you all to get in early? So put your expressions in early. We don't want to be at the back of the queue for this because we never make sure that we're going to make sure that we're not at the back of the queue, because actually I think the first come first served on this one again, but actually just trying to get people to make sure that we have a look at the specs, sign up, any kind of questions, happy to receive those to myself, Layla or Jenny. Again, like I said, would be to try and push on and get those implemented. Just on a COVID update vaccination data, jumped one. So again, it's happy to share these. This is again, as I said, it's a good picture. Newham obviously is top of the tree for TNW. Again, gives a bit of a cohort basis. So again, it's a thank you and well done. Obviously, I know it's not a sprint, it's a marathon, so there's still lots to get on to. But it was just really today to kind of go through the stats. And I know Karen, you're on the call, and John, certainly from point of view of whether you want to lob in anything around the primary care questions. And I know on some of the chat bar, I haven't, again, as they ping in, they're quite distracting when you're trying to present and questions, so apologies if I'm off beam. But thank you for the questions. I know there was one in there about, what was it?
There's one about Pfizer
in GP practices.
Yeah.
There isn't at the moment that ability. We are pushing that hard and fast to see whether we can get that done. So there isn't anything at the moment. I know there was a conversation of potentially pop-ups, so we could try and work through the system something differently. It is about navigating, unfortunately, the rhetoric of NHS England, what you can and can't do. So we are pushing that to try and do that. And again, I'm sure you're all aware, there obviously will be further stages and iterations of the whole programme that may allow us to switch on new sites and change that ability of being able to offer both. So again, these data packs are going to be shared anyway. Again, for me is just a ploy on making sure that we've got all the care homes contacted and making sure all of those residents, new and existing patients, just to make sure that we've got all those tied off. So hopefully all should have had now their offer of the vaccination. Again, it's the list cleansing conversation we had at last month that I know Jenny talked about. So again, it's just trying to make sure that people kind of have the cleanest list we can get. Again, for certainly around the COVID data, around the support, obviously support from ourselves, obviously the Fed and local authority, and actually just around the dispersal where we can kind of work that through. I won't go through the other 3 slides, but it's more around the cohorts. It's very small. You won't be able to see it even with the best eyesight. But we just felt that it was able, again, some of the KEG data for people to see on the cohorts and on a practice basis, thought it might be helpful. So whistle stop tour, again, just mindful of time. Happy to take any questions. I'll stop sharing now.
Perfect. Thanks, William. Can't see anything else specific in the chat bar that's come across. But if there are any questions later on, then I can feed that back to you.
Thanks.
Perfect. Okay. Thank you. So next I'm going to bring in Lorna and Dr. Vathanem to speak about diabetic foot disease.
Hi, everyone. My name is Ramu. I'm one of the endocrine registrars at Newham Hospital. So can you hear me okay?
We can, yeah. Thank you so much for joining.
No, thank you for having us. I think Lorna's on the line from Diabetes UK.
Yes, I am. Hello, everyone.
Yeah. Hi. And Dr. Goetz, who's one of our diabetes consultants, so he's also on. So I'll share my screen. Get started. So we're doing this talk as a result of the recent audit that we did on all referrals to our podiatric clinic for diabetic foot problems. So this is between January and April this year. A total of 158 referrals, and 13% of these were for neuropathy. And this was a real variety of patients. So some of them were for neuropathy alone, some of them might have been for painful neuropathy, and others wasn't much more information, but when they were seen, there were other higher risk features, such as having ulcers or other problems. So low risk neuropathy patients without any other features don't always need the foot health clinic, and often they'll be advised on basic support and self-management, can be discharged. So Newham unfortunately has one of the highest rates of amputations in the country. So we've got data from 2014 to 2017, and the standardised rates of amputations were 12.3 per 10,000 patient years, and that's compared to 8.2 for the country. And there's 49 total in that 3-year gap. Most neuropathy can manage primary care, and actually the majority of management is by the patient themselves, and that's the most important part, is making sure the patients know how to monitor their feet and when to seek help, because they're only going to see healthcare professionals, either yourselves or us, a few times a year, and a lot can happen in between those times. And this is the current referral form just here. And we are looking at updating this because it does list neuropathy as a moderate risk feature, but we'll go through that a bit more later in the presentation. And we hope that by reducing the number of patients that have to be seen in the clinic, we can allow our podiatry team to focus more on the higher risk patients who are more likely to need an amputation and try and prevent that from happening. So today we're going to talk about how patients can be managed, and our end goal is to prevent ulceration and prevent amputation in these patients as much as possible. So we'll talk about how we can manage neuropathy. So first part is to how to screen and examine patients. We'll talk about how we can advise patients, how we can manage neuropathic pain, and when these patients should be referred into the podiatry clinic. So patients sometimes come complaining of symptoms of neuropathic pain. This could be they've got burning pain or paresthesia, pins and needles. It's often worse at night. I think about vascular disease in those cases, but usually vascular disease pick up clinically. Also, if that will be relieved when they dangle their foot off the side of the bed to improve the distal flow. And they may also say that they don't feel heat as much as normal, or that they don't feel their feet hitting the ground and they feel numb. Importantly, it can actually happen without there being an actual sensory deficit. You may examine the patient, there's no signs of neuropathy, but they still may have very significant neuropathic pain. It can be quite debilitating. So on examination, so we're looking at the feet carefully. So looking at the skin, see if there's any dry skin. It's very common in diabetic patients. If any calluses or corns, any ulceration or skin damage or break, any discoloration. And also looking at the nails as well, see if there's any pathology there. And assess the vascular status by feeling for the pulses. Also examine sensation. So for sensation, the gold standard really is to use a 10-gram monofilament. As you can see on the diagram here, you just apply enough pressure for it to bend and hold it for around a second and ask the patient if they can feel it. A lot of patients, particularly if they've had lots of checks before, will try and precipitate and preempt what you're doing. It's important to make sure that eyes are closed and that the patient is actually only saying yes when you're actually touching and not just trying to guess. We test in 5 spots on each foot. So the tips of the first and third toes, and then the heads of the first, third, and fifth metatarsals. And you go higher up if they've got the sensory deficit. The next alternative would be vibration with 128 hertz tuning fork. And again, you start at the distal interphalangeal joint and then work your way up proximally if there's an issue. And lastly, if none of these are available, you can use the switch touch test, which is essentially the same areas, but instead you use a finger and touch lightly for 1 second and ask the patient if they can feel that. So quite commonly, we can't feel a pulse. So the first thing is to see if the patient has any symptoms of vascular disease like claudication, or if they have any signs, for example, they've got cold feet or any discoloration. And most importantly, is there any tissue loss or ulceration? So if they've got any of these and they need a more urgent vascular referral, going to A&E, they've got some velocity. And otherwise, if you just can't feel a pulse, it may be an anatomical variant, but these patients should probably be seen by vascular actually, but it's less urgent if they've not got any symptoms or signs that are concerning. So this is the most important slide, is patient education and the patient being able to manage themselves. So the first part is to avoid any problems. So avoid going bare feet around the house and avoid any heat. A lot of patients try hot water bottles, but they're not going to feel the temperature of that. There's a real risk of causing skin damage. Also to ensure their footwear is good fitting and make sure they haven't got any foreign objects like stones inside their shoes. Occupational footwear can be quite tricky. So some of these patients will need podiatry to help because the footwear may be adapted to protect them, for example, from falling objects, but it's not necessarily the best thing for the feet themselves. And the patient needs to be checking their feet every day for the same things that we are and looking in their shoes. They need to know when to seek help. So when they do notice an ulcer or problems, then they should at least seek help themselves, and we can see those patients within 72 hours in the foot clinic. Or if they're unwell or it's significant, they just go to A&E. So neuropathic pain is a real problem for patients. We have 3 main groups of agents we can use to treat this. So first is duloxetine. I feel this is probably the best one because it has the added benefit of being an antidepressant As we know, depression is quite common in diabetes. They start at 30 milligrams, and you can up titrate after a few weeks to 60 milligrams if it's ineffective. The main cautions to be aware of here are if patients have cardiovascular disease or arrhythmias, some evidence that it can increase the risk of those. You might want to avoid it. You can use tricyclic antidepressants, amitriptyline, and again you can start at 10 milligrams and slowly up titrate. And the main side effects here are antimuscarinic effects of constipation, urinary retention, careful glaucoma as well, and can make people drowsy. Lastly, you can use pregabalin or gabapentin. We start at 75 milligrams twice a day. So these are controlled drugs. You have to be careful of dependence, but also they can cause drowsiness, and particularly patients who are more elderly or have liver disease, that can be an issue. And these patients could definitely be discussed in cluster meetings with our team. If there's no other indications to be seen in the clinic, we can still provide support through that to manage their pain. So lastly, let's talk about when to refer on to podiatry. So patients who have neuropathic pain or peripheral neuropathy without any other features, often in the podiatry clinic, they'll be educated, feet checked, but they probably won't do anything else, and they'll likely be discharged. So patients who should be seen, anyone who doesn't have neuropathy but has significant callus is at moderate risk because that can progress to ulceration.
Sorry, you've just been cut off there. I don't know if you're on mute. Okay, I'm not sure what's happened. I will just wait for just a few seconds to see if they come back on. Lorna, can you hear us?
Yes, I can hear you fine.
Do you want to just quickly, I think we'll leave that sort of presentation there, if you don't mind. If you just want to quickly just mention what you've put in the chat bar, just about the information.
Yes, thank you. So hello everyone, I'm Lorna Adamson, I'm the Improving Care Manager for Diabetes UK London, and I've just put a few resources into the chat bar. So we have a foot care leaflet available, which you can download from our online shop, or is also available to order as a print resource for those who are seeing face to face. And we also have our information prescription tools, which are something that can be integrated into primary care IT systems. And it's a one-page information resource, and you can go through it with the patient and set personalised targets and goals with them. So they're also available on our website that I've just put into the link. And we have some other web information which I'll link to as well, so you can have a look through that at your own leisure. And yeah, sorry, just to update that we are at the very early stages of doing some northeast wide foot care work, some improvement work. So if anyone would like to be involved in that, then please do let me know. I'll put my email address in, so feel free to get in touch.
That's great. Thank you so much, Lorna. I appreciate you both coming today. Great. So I'm going to now move on to the
Hello.
Dawn. Hello.
Ram, we had a problem with his computer. I think he's joining back to finish the presentation. Sorry.
That's fine. I think what we might do is, because I think Lorna's put in the chat some of the links as well, so we might end the presentation there, if that's okay. And what I've suggested is that if we have any questions, because Dr. Tammy is our local diabetic lead, and she's not able to join us today, but we might take some of this forward and extend it into a training session, as Kavita suggested in the chat bar.
Okay.
And if there are any questions, we'll hand them over, if that's okay.
That's all right. Okay, thank you.
Okay, thank you very much. Right, now we're joined by Dawn, who's going to talk to us about the child exploitation. So Dawn, hand over to you.
Thank you very much. Can everyone hear me all right?
Yes, we can.
Oh, good. Hello, everybody. Thank you for inviting me here. It's the first time I'm attending. My name is Dawn Henry. I am an early help coordinator from the council. So my main role, I run manage a number of early help services, and we support families when they need them. when they need that support. So it could be at any point from 0 right up to 18, but also 25 if the child or young person has a special educational needs or disability. So we provide whole family support, and we have a number of services that do that. So today I'm here specifically to talk about exploitation and some of the work that we're doing as part of Newham exploitation strategy. So I'm just going to share my screen. Okay, you should be able to see this. So I'm going to start by telling you a bit about the new exploitation panel that is part of the early help landscape. So this is called Preventing Child Exploitation and Harm Hub, PEC for short. So you're going to hear a lot of PEC. And the aim of it is to really look at those children, young people that are presented with emerging concerns and vulnerabilities in the hope that we can intervene early before they get into any kind of gangs or counting lines or any other forms of exploitation. Many of the children that are coming and being presented at the panel are presenting because they're being permanently excluded from school. They may be possession of a weapon because they're concerned about their safety in school. It could be that they're experimenting with cannabis or are using alcohol, or there's concerns around their friendship group and peers, including mental health, as well as ongoing family concerns and family conflicts. So the range that we're seeing at the moment is quite clear, and some patterns are beginning to emerge. So the reason why I'm here today is really for you to have an understanding of how this panel works. It runs every Tuesday from 9:30 to 11:30. And we have a range of partners that attend. So we have our partners from health, some of the early help services. We also have adult safeguarding team, as well as Head Start mental health support service, as well as some of our community and voluntary services available to support and offer interventions where necessary. We also work very closely with our schools. So the schools attend, one, to impart that intelligence and understanding about why that referral has come in, but also to look at what have they already put in place and how they can work with us as part of a coordinated response. All our referrals come from the front door, which is the multi-agency safeguarding hub. So as you're probably aware, any member of the public can send a referral in about a child that they're concerned about. So we have a mixture of referrals from police, from A&E, where sometimes young people attend because they have maintained injury or serious injury. All of those come in to us, and the decision is made at that point in the MASH whether it's met threshold for a social care intervention, and therefore they will be assessed by a social worker. But as we know, many of those children will not meet the threshold for social care because it's not acute, it's not at that level of complexity. And so all those children will be sent to the PEC for that multi-agency discussion, but also a plan to go forward. So that is the new PEC meeting. As I said before, we have a range of professionals that attend that meeting, but we also have a QA aspect. So the quality assurance team attend and give us advice as to how we can refine the process and ensure that we maintain oversight of those children. At the point, we've had more than 26 at the moment, so there's about 40 children that we've discussed. The other thing that we do, once we discuss them, we don't leave it there. So then we task the group to actually put in the actions as agreed. And then we ask them to bring it back to the panel just to check that everything's in place and that that child and young person and their family is getting the support. We're also working on a PEC dashboard with infographics that I'll be happy to come again and share with you in terms of the trends that we're seeing. We're not just looking at families, we're looking at the associates. So we're looking very closely at the peers that they're forming, if those peers are known to social care, and what are the increasing risks for these children. We also will have a monthly PEC newsletter, which I'll be sharing with all of you so you can keep up to date on what we're finding now, working closely with the police. So one of the things that we're going to do, we will have a PEC team that sits behind the PEC meeting, and they will be available to provide some one-to-one support for the young person, But also our work is always family based. So we're also picking up the concerns that may be within the family home. There may be domestic violence, ongoing parental conflict, or intergenerational conflict that we're seeing a lot that's impacting on how that child feels and possibly leading them into exploitation or doing things outside of the family home. We're also intervening at the peer group level, as I said before, having an understanding of what's happening in those peers and whether they're a negative or positive influence on the child or young person. We're working very closely with the schools. What is coming back from the schools is that we're noticing that there's a lot of children, young people that are carrying knives into school, as you probably are aware. But when we dig deeper, the reason for that is because they're not feeling safe. So we're looking and working very closely with our schools, especially secondary schools, to kind of see where are the unsafe places in schools. We know sometimes that children are actually using the behavior policy, and I'm being really honest, they're using the behavior policy as a safety mechanism. What do I mean by that? I have read where a young person had repeatedly been put into detention because they were attending school late. When we asked that young person, why are you coming in late? They said, we know that when we come in late, we will get detention, and that will allow us to avoid the peers that we don't want to see because we're fearful of them. This information is crucial, as you can imagine. We're also hearing about peer-on-peer sexual abuse within schools and around schools. So it's really important that we work with our school professionals, and they're very much involved. As I said before, we're hoping that the PEC team will be able to intervene at many different levels. Individual work. We're also launching a very exciting program called DICE. There isn't no reason why it's called DICE, but it's just called DICE. It's a Bernardo's program, parenting program, and it's an awareness one. So parents and a lot of assumptions are made that parents do know about exploitation. They may have an understanding a little bit, but they don't know the signs, the indicators that they can look out for. DICE will do that. We'll be able to accept referrals from parents that want to be part of this, and they'll be given some information about the teenage brain, teenage behavior, what is normal, what is abnormal, and things to look out for, and also understand about online dangers so they can keep their child safe in advance. We're also going to do some real talk sessions with the groups, with the individuals and their peers, to get an understanding and infiltrate the wider group. And we're also going to be looking at other interventions that we could put in place for that child and young person. As part of Newham's exploitation strategy, we have now recently launched the exploitation screening tool that we're asking our partners to complete. Now, before you start worrying, because we're very, very aware that you don't have the capacity to complete this form. Don't worry. What we're saying is, as you normally do, and I've seen the referrals, if you can just continue to send referrals as normal to MASH, where a child or young person has come to your attention and you feel there are concerns. Now, it doesn't have to be just exploitation. It could be anything. We will pick them up. It could be that you're aware that there's ongoing tensions within the home. There's mental health. Mental health is coming up hugely in my particular neck of the woods. All those kinds of things, just continue to do that. But we're asking all our other partners that if they do suspect that there's emerging needs or even real evidence that this child is involved in some form of exploitation, that they complete this as part of their MASH referral. And we're using that information to assess risk, but also decide which part of the service is most appropriate or whether it does need social care involvement. Lastly, I just wanted to let you know that if you wanted to talk to me or anybody in the team specifically about children that you think may be at risk, we're looking at year 5 now, because we know that that transition from primary secondary is crucial. We do know that schools are aware of those children that will find it difficult in the secondary school. Year 7, as you know, is quite a hard year. They're trying to find their feet, build new friendships, and get used to the bigger situation, the big school. But we do know from year 8, that's when we start to see those issues appearing. So the more we can do in primary school and when they're younger and start putting those interventions in place, the better it is for them and the family. So I would encourage you all, think about your families, think about the presentation, and if you have any concern, please send a referral and we will pick it up from our end. So that's generally my presentation for today.
That's great. Thank you so much, Dawn. I wish we had more time because I think there's lots that we obviously want to discuss further with this. And it may be worth, obviously, I know you're connected with the safeguarding team. So I think, if there are any questions, we can raise it with Emma or Sabina, who are our clinical leads for safeguarding. But I appreciate your time today.
No, thank you. Thank you, everybody. Take care.
Thank you.
Bye.
Thanks. So I'm going to hand over to Dr. Kate Adams now, and I know Claire's on the call as well, so it's quite an important topic to talk about. So my apologies for everyone. I hope you can just stay around for a little longer.
Yes, thank you very much. Can everybody hear me?
You can.
Yeah, great. Okay, and can you see my presentation?
Yeah.
Yeah, okay. So I'm going to talk to you a bit about 111 and what's happening with 111, and also really how this impacts on us in primary care. I myself am a GP in City and Hackney, and I also work in the out of hours supporting 111. So I'm going to quickly, I'll explain pre and post COVID activity so you get a sense of some of the pressures around. The increase in primary care activity that we are finding is coming into 111, which never used to do that in hours. What do we do with primary care activity generated by? Where does it go in the system? And a bit about GP practice booking, because I know that everybody's very keen to think and talk about that with a few questions. So I've only got a handful of slides. So the first one just shows you in September 2019, the NEL, North East London, had 42,000 calls into their 111 system. The 111 system is run by London Ambulance Service. And Newham had 5,118 calls, but when you look at it's doubled the activity. So in May 2021, the system went from 42,000 to 18,000. In Newham, it went from 5,000 to 18 calls to 100%. Now, the thing is that when you call 111, a third of the time it ends out with you need to be supported by primary care. That's a third of the time. That was back in 2019. We now find that is between 50 and 55%. Now, between May 2020 and May 2021, we have seen excitement in positions, the 2 hour and the 6 hours. 111 says you to person, it's necessary. What we're also finding is that there isn't any place for these to go. Reasons. So many of these patients with primary care needs are ending up in the urgent treatment. So these are the primary care dispositions that are being directed to GP practices. As you all know, you have one in, and these. What we're very keen in North East London is that if a patient has a registered general practitioner and they phone 111, if a primary care disposition is generated, that they go back into their own practice. In my practice this morning, we have 3 slots. 2 of those were booked by 111. One was a case last night, and it was a 24-hour disposition, and it was for an 87-year-old, and I spoke to that patient this morning. And then another one was booked in at 11 o'clock. We've got another appointment later on in the day if 111 needs it. Now, what we have clinicians in 111. So you could say, why aren't they able to deal with these primary care dispositions that call 111? Well, essentially, the volumes are absolutely huge. We may have between 15 and 20 clinicians working, covering the whole of North East London as we speak. And what they're dealing with as clinicians, they're nurses, paramedics and GPs, they're dealing with the frailest of patients, they're dealing with the under 1-year-olds that call 111, they're dealing with complex calls, they're dealing with speak to primary care dispositions that are generated, they're supporting validation of ambulance requests, and they're dealing with ambulance crews on scene. So they're already very, very busy. Now, this slide I wanted to show because I think actually Newham does a very good job in terms of the primary care offer it does across the system compared to other CCGs. You have a very well developed GP out of hours service. You have your hubs, and already you're in a practice. We're not seeing a lot of cases necessarily going to the UTCs, but things have changed since this data was pulled. Obviously, we all know that primary care is really busy. Obviously, the impact of COVID has impacted the Delta variant. We've now got peds, RSV presenting. And the messaging to patients is incredibly confused. I mean, locally, we're very keen that if you have a GP, you use your GP. That's what we want in ours. But of course, you've had this 111 First programme. You will see adverts that say, if you don't know what to do, call 111. We even have a number of practices that when they have no appointments left, and I experience this in GP out of hours, what we find is the GP receptionist has nowhere to go and they say phone 111. And of course, 111 has nothing else better to offer the patient than the surgery itself. It's going to try and get the patient back into your booking if we can. So why are we seeing this increase? And one, obviously patients vote with their feet. Some are not using their general practice route for whatever reason. Some are confused about the messaging, and also we have some practice behaviours. So access is challenged. We know that. We're all very busy. The on things that practices are using, we know that 8% of those generate a phone 111 or speak to your practice urgently. And some practices no longer support same-day urgent care. I'm on call today in my practice in City in Hackney, so I kind of want to deal with everything that comes my way. I don't want my patients using 111, but some practices are hugely challenged, and they are actually telling their patients to phone 111, which is causing an issue. As I said to you, Newham has a very good primary care offer to support 111 already. There's a risk that patients will bypass their own surgeries. 111 is trying very hard to direct appropriate codes to pharmacy services. But what we're finding is that a lot of patients just point blank refuse. They say, I'm not going there. I want to see a GP, talk to a GP. I ain't going to pharmacy. So we are trying very hard and looking at ways that we can improve that. So I just thought this might be helpful because in April 2021, this is Newham data, there were 9,965 calls for Newham patients, and 50% approximately of those needed a primary care response. So that's 4,982 calls for the whole month needing primary care support. So 1,700 or so GP out of hours provided those. We had some home visits, obviously. 232 were booked into hubs. And the GP practices, I think you've got 46 or 47 practices, provided 889 appointments, which is approximately 0.67 per practice per day. Now, obviously, some practices are much bigger than others, so just doing a crude calculation like that isn't, the way to go. But I just wanted to give an indication that there's a lot of underutilization going on. And 746 requests to get a patient back into their own practice was rejected, and I'll show you a slide of why that happened. So we know currently in Newham, as of April's data, we're short of about 2,000 appointments, some of which will end up in your UTC emergency department if no other place can be found for them. And obviously we want to avoid that. We want to contain these in a primary care environment. Now, certainly primary care could take more back if those appointments were utilised. And when I look at the for Newham, the reasons why they were rejected, the biggest reason was no appointments were available. I think it's very important in terms of when those appointments are timed. We did a piece of work across North East London, and 90% of the time, the person doing this research said that practices weren't actually offering their 1 per 3,000, that they're encouraged to do so. And then sometimes the appointments didn't meet the time frame, so it couldn't be booked. So we had practices that might have an appointment at 10 o'clock and 10:15, which is not necessarily good for 111. If they receive a call or want to refer somebody at 10 o'clock, it's too late, not enough time to get to the surgery or talk to a doctor, whatever, you see. So there is a mismatch. So I suppose my last slide is I think Newham's doing a very good job so far in terms of the primary care support it's offering, but we've got this unmet need. I think that we could improve the practice utilization. That could be done, and that could probably absorb about half of the appointments. These aren't great numbers. You wouldn't be overwhelmed. But the problem is, if there are some practices that are using 111 as their same-day urgent care, primary care demand, that is a challenge for the system. I just wondered whether the next potentially might have a think of way if practices are very challenged and really can't manage. Could the practice could the ends offer support? Because people may have questions to me. and I'm very happy to take those. I'm aware, obviously, you're under a lot of time pressure. I'll stop sharing my screen.
Thanks, Kate. That's really helpful. I'm going to bring Claire in a minute. I just wanted to say I think there are massive demands across the system. I think it's not just primary care. I think it's the front door, and what we're noticing is even if we are having those 111 slots available, it's how are they then being utilised by 111 themselves. And we fed this back to Claire, and I know Claire's got liaising with yourselves and those at NEL to work out, because what we're seeing is actually the slots that are being used are for actually non-urgent things, which are being triaged by 111, thinking that they need to be booked on the day when they're actually not urgent. So it's kind of, I think it's a whole system approach. I don't know if it's just sits with primary care. I think it literally, we need to sort something out in Newham to really manage that front door as a system. I'm going to bring Claire in.
Yeah, well, I'm wondering if I should bring Laura in actually, because the two GPs who contact us about 111 tend to be Laura and Kavita, and I know Kavita had to leave, so I don't, Laura, if you want to give any feedback.
Yeah, of course. Like, you know, I sort of fed back about a case this week where a potentially evolving CVA was booked in with myself for a 2-hour callback. So that's the other end of the spectrum. But then I have had GPs at my practice talk about other stuff that has been booked in that's chronic. But I do very much feel for the call handlers and the clinicians at 111 because of like what Rima said and Kate have said about the sheer volume. I think though that, and very much you sort of said that you realise that this is obviously because of all the access problems anyway and the demand in primary care. It's just, I guess I'm struggling to see how else that we can help when we're already at our limits. I do know that obviously there are, I spoke about this in the last meeting, there's obviously a wide range of access across Newham. Some practices are open full, like what you've said, Kate, about I'm on call, so we don't divert anyone to 111. We are like that, but it is unmanageable at the moment. And some other practices are saying, no, sorry, we're full. And again, Kate, I think in City and Hackney, you've got that great contract where you've got the on the day demand doctor contract, which I think helps with that. We don't have that here in Newham. And we are sort of hopefully trying to make some movements on that with support. But I think the two ends of the spectrum don't work, do they? Where you close very early and then the patients can't get in at all. But the other end of the spectrum, which is where we are, also isn't working.
Yeah.
So
I mean, sorry, Claire, go on.
No, you can.
No, I think the problem is, you see, 111 really wasn't set up to deal with sort of routine primary care, and I think because of patients and behaviour or practice behaviour or access issues, they're coming into an urgent care system, and they didn't have an urgent care problem to start with, and then they go through the NHS pathways, which is risk averse. It's supposed to be safe, so it spits out you need to see someone in a more urgent time frame. And when you say to a patient, oh, actually, you need to see your GP in 3 days, can you go away? They go, no way, they're not going. No one talks to me, no one will see me. And so it is very challenging. So I think that, I mean, in our practice, we just these are our patients that we didn't want to call 111. We don't want them calling 111 at all anyway. We want to manage them. But where do they go in the system? Because if they're phoning 111, we've got this offer of practices. So I think practices could potentially look at the timing of appointments. Having them later in the day will probably help 111, and ensuring that they're all opening and access. Because I think actually per practice, the numbers are really not very big that would go back. And these are your patients that you know, that you can contain, and it's a phone call. You know, often it's a phone call. So I often look at the 111 and it's just, I close it on the phone really. But I do agree, some people get frustrated. Why is there this on the day slot when I'm so busy being taken by 111?
So can I just jump in just for, so when we went through the numbers yesterday, Kate, we were thinking it was probably about 150 appointments a day, absolutely max. And I think that was in 24 hours, not even in hours. So I think William mentioned earlier, so Rima, you're sort of saying, I don't know what we can do, and Laura, and And I think there are things we can do. I mean, there are a couple of practices where they're over offering 111. There are other practices where apparently it's become clear they aren't offering any 111. So even if every practice just offered some 111 and made it at the end of the morning clinic or the end of the afternoon clinic, it would be more likely that they would be used. And then also the Federation has been asked to provide an extra clinic for 111 filtering. So that's providing 50 slots a day. So just simple things like that would have some sort of impact. I think the other thing is that we're hearing from London Ambulance that patients are getting really quite aggressive. They're really noticing they're on grade 4 alert or something. So, you know, the system is enormously under pressure, which makes everybody very scratchy. And I think everybody's moaning about everybody else, which is how we all sometimes behave when we're under pressure and are at our worst. So it's just appreciating that it's not a perfect world. The NHS isn't a perfect system and people aren't going to behave perfectly. So you are probably going to get inappropriate people booked in, etc., etc.
And I think, Claire, there are practices where the demand is more, but I don't think the answer is by having more 111 slots for those practices, because I think at the moment the worry would be then they're going to be used inappropriately, and then that's going to reduce the number of appointments you could have offered for those that have called in, let's say for the morning for the same day appointment. So it's getting that balance right. The first
but we understand there are some practices that aren't even offering their contractual obligation of appointments.
Yeah, so that's the first step, isn't it? Yeah. To make sure that, you know, everyone's doing what they're.
And if they are, they're not offering at the best time, so they can be used by one.
Sure. I'm going to bring in Dr. Patel, if that's okay.
What happened about the dental patient? Do you refer them to dental practitioner?
So toothache is probably one of the biggest reasons people call for symptoms, and we have a very good, if they call in hours, there's access to dental nurse triage. And we try and put them into practices. In and out of hours, there's a all singing, all dancing professional nurses, dentist nurses that support them. The problem is we have loads of patients who don't have dentists and present in out of hours. So it's a big problem, but they should never be sent. It's a mistake if they're coming back into your primary care. They shouldn't be coming into primary care. They should be managed outside. You shouldn't be seeing any dental. And if you are being referred to any dental, I'd like to know about it.
But many times they go to A&E.
Yes,
this is a real problem and disparity.
Yeah, no, I mean, we obviously would like them to be registered with a dentist, but we know that doesn't happen. So believe you me, it's the biggest symptom reason that people phone 111 is toothache. It's huge, but we have a system to support them. And the problem is NHS dentistry their contract is hugely flawed and problematic, and there isn't the urgent and emergency supply that's needed in London. So it's a huge problem. I mean, I suppose from my point of view, if practices, I don't know who can support this, could look at this offer and look at the timing of their appointments, that would be hugely helpful. And if there are practices that really are struggling and say we can't cope, we are really not coping, and so actually our receptionists are telling patients to phone 111 instead of using us, I think it would be really helpful to see if we can try and support a local solution, because 111 doesn't have a solution in ours to support these patients really. And as activity is getting busier and busier, it would be interesting to see if locally those practices that are really struggling could potentially be supported, because primary care massively supports the urgent and emergency care system. We for years have been seeing the majority of urgent care patients with our primary care urgent. That's what we've been doing for years on the day. And if practices are falling over and are struggling to do that, it's where can these patients be seen and supported out of an emergency department and out of an urgent treatment centre environment. That's what we were trying to achieve.
Thanks, Kate. I'm going to bring Laura in, and then I know Claire's put in the chat about if there are any inappropriate bookings, and to obviously let her know. Laura.
Hi. Yeah, this might sound a bit stupid, but general practice obviously isn't for urgent or emergency care. We do obviously get a lot of those calls in when we're on call, and I've never been able to find clear guidance about in hours what would actually be better cared for by 111 compared to GP practices, because I understand, obviously, Kate, you're saying about the timing of the 111 slots. However, we get lots of urgent stuff that comes in, can be 6:30, sick child, this, that and the other. And if we've got a load of the 111 calls at the end of the day, we're already dealing with a lot of urgent stuff. That's why we're leaving at 9, 10 o'clock at night. And actually, there needs to be much better and clear guidance about what we should be seeing and what we shouldn't be seeing, because I still can't get my head around what is more appropriate for 111 in hours and what's more appropriate for general practice, because we're not an urgent service.
Yeah. I mean, I suppose for us, 111, I mean, 111 isn't designed really to pick up a patient who's got a problem, wants to speak to the GP, that's it. Or it's a perceived problem, a perceived urgent problem. Let's put it that way. And we have always mocked that up in primary care. We've done that for years. We've had on-call. I don't know whether most practices have an on-call. I'm on call today, and I'm dealing with anything that comes my way. And that's how I've worked as a trainee, and I've worked at about 3 or 4 practices. And so we suck up what comes our way in hours. That, and obviously if something is an emergency, we have to go, I'm sorry, I can't deal with this. This needs this. 111, anything that comes into them that is very urgent, they would obviously deal with that. If it needed an emergency department, it needed an ambulance. But actually, with your own patients, it's the continuity. You know them well. So really, we want people to manage their own patients where they can and is possible, because that's the best place for people to be. Now, I totally understand that the pressure is so huge. People are really struggling. So it's really what in Newham, if practices can't cope with those calls. I mean, the numbers coming from 111 are tiny. What do you want to do as a system? Where do you want these patients to go? I don't think the right thing is to say we're sending them all to 111 in hours, because 111 has to pick up all the out of hours, everything else. That work I said that they're doing already. We have a lot of unregistered patients that can go nowhere, that they're having to try and support. So I think really it's for Newham to think through, what should we do, and how do we support practices that are really struggling? Because I'm aware that some practices manage well for whatever reason, their systems are set up in that way, and some practices are not. And I think just trying to understand how they are supported.
Yeah, I think it goes back to what Nadeem was saying. Oh, sorry, my connection's bad.
No, you carry on, Laura. I think we can hear you.
Sorry. Yeah, it was just going back to what Nadeem was saying, is that access is really, really difficult at the moment. Demand, I should say, is just really intense. So, yeah, I don't know what the answer is, but I do think that the support that some of the other areas have got, I think would work very, very well for us. And also, I think if we are already providing far and above what we're contractually supposed to be providing in terms of the number of appointments per 1,000 patients. For example, we provide a lot more than that already, but still have very, very intense on-the-day demand, which we deal with. So it feels like there has to be a cut-off point at one point. And yes, you're right, continuity of care is incredibly important, and that's why we work how we're working. But if we're already providing so many more appointments than what we're actually supposed to be providing for, and then trying to do this on top, this is when it's becoming unmanageable.
Can I just say something about that? So I don't want this to be, sorry, it might have been misunderstood. I think you have a generous program is one of the top callers to 111. So City and Hackney has the fewest in now. So it's proportionate. You have a lot more of your patients phone 111 than other CCGs. You're second, I think, in the list. So you're generating more activity. But what I'm saying is you're very good at being able to support that activity to date. But because of the numbers of calls. Now, why you have a young population, maybe there are people that are not registered, struggling to access, maybe there's some access issues, but you're high users, which you need those appointments. And I think that when we looked at how many practice appointments and how many were rejected, there is potentially slack in the system. These are not great numbers, for a practice. I've got a practice list of about 9,000 here. We've got 3 appointments booked, and you will not be rammed. But if you've got a practice, say that's quite a reasonable size, and they're just referring everybody on the day who needs a what, you know, to talk to a doctor or feels they've got perceived urgent care need to 111, that's where you have a problem. So I don't think you're going to be overwhelmed, and I think you could really, because obviously the whole system is struggling all over the place, A&E departments, and we're just going to see things get busier and busier and busier with this RSV now outbreak. So if we can, where possible, contain the patients that are ours, that's what I think we really need to encourage, because it's just best for them. And I think Newham to date has really not directed too many children to UTCs. They've managed to support them, but I think that's going to change if we can't get more of these patients back into primary care in the appointments that potentially should be made available.
So I don't think we're obviously going to find a solution today, but I think, Kate, it's been really good to have you on today to sort of explain what the situation is with 111. It gives us a better understanding of what's going on. We obviously have our channels through Claire and the Urgent Working Group, which we will sort of take on. I think the first thing is to make sure that all the slots in primary care are being utilised, and you know it's equitable across the borough. That's the first thing I think we need to do, and that's come out from today. But I'd say we could talk about this.
Of course. Yeah, no, I'm sorry.
Today, but that's been really sort of helpful to highlight the issues.
And if any questions, do get in contact with me, or any issues, I'm very happy to talk to them. Thank you very much for your time.
Thank you, Dr. Adams. Thank you. Sorry, for the last few minutes, I don't know if Imran's still on. If you want to talk through your bit, or we can always have it for another meeting.
Rima, I'll leave it up to you. I know I had the graveyard slot and 10 minutes, and I knew it would be squeezed. So I have squeezed it to 2 minutes, but 2 minutes does sound a bit painful now. It's 23 minutes past 2. So I'll leave it completely to your discretion.
Are there any highlights, Imran, you just want to mention?
Fine. So it's just two things. Yeah, forget the presentation. It's two things really. One is to just let everybody know that we are doing okay with our SMI COVAX vaccinations. It's around 60%, but obviously we need to do that a bit better. So what I've done is I've tried to make, so what the first thing we need to do is practice, if we can just, I just wanted to encourage practices to, if you just share the last, the third slide, that's really got all the information, the one after that. So I just wanted to encourage practices to do searches for these vulnerable cohorts, so SMI, LD, and dementia. We've tried to work through the ease. I've been back and forth about this, trying to work out the easiest way so it doesn't put extra burden on practices to do extra searches, because you're doing all the others anyway. So kind of with the help of Bhapinder, I've kind of worked out that if I create the searches, I upload it to the NHC folder, then practices can just export it and run it. And what that will do is what we can't get from a population or borough level is give us patient identifiable information for the practice to use. So we don't want you to say, oh, encourage your patients to have vaccination, because obviously clearly that doesn't work. So what I've tried to do is I'm going to send around kind of an abridged version of what I put here. So whoever's kind of dealing with patients, doing the calls, recalls, has a one-pager of knowing what's the extra offer that we can give. So we all know there's the usual channels, you call the patient, recall, but for specific groups, there's certain things. So again, I don't want to read through all of that, but use the LBN support, telephone, peer support workers. Highlight again on there is that via LBN, they've secured funding for 3 posts who will help with outreach in vaccination, and they'll be based within primary care. And that's a really flexible model. They go out to homeless people and all sorts of things. So that's one thing that we can use for all those we're struggling with. And then for kind of SMI, LD, and dementia, I've just kind of listed some names and places you can go to for support. So kind of identifying your patients, and then those you're struggling with, get some support, because we're trying to build a support package within the system. That's it for me.
Thank you so much, Imran. I feel bad that we had to leave it there. But if there's anything more, we could probably add on the NHC webinar as well in a couple of weeks, if there's anything more you want to expand on. Perfect. Thank you so much, everyone. I know it's Friday. I appreciate all your time today. So have a good weekend. All right.